Coming to the next case, a person is brought to the emergency department in a comatose state with fruity odor of breath and rapid deep labored breathing. On examination, the BP was found to be 110 by 80 mmHg. Pulse rate was 94 per minute. Respiratory rate was increased, which was 46 per minute. The blood investigations revealed RBS, that is random blood sugar, 450 milligram percent or milligram per deciliter. Urine ketone bodies were present. Serum bicarbonate level was 13 milliequivalents per liter. Plasma pH was 7.16. Sodium levels in the serum 126 milliequivalents per liter. Serum potassium levels 6.5 milliequivalents per liter. So what is your diagnosis here? So let's see how the case was brought to the hospital. He was in a comatose state where his breath was smelling fruity. Then he had deep labored breathing. So, and the investigations, there is high blood glucose level, random blood glucose, then ketone bodies are present, bicarbonate levels are decreased, pH is decreased indicating acidic state, serum sodium levels are decreased and serum potassium levels are increased. So looking at all these, we can come to the probable diagnosis of diabetic ketoacidosis. Now what happens over here, diabetic ketoacidosis is a acute complication of type 2 diabetes mellitus. So what exactly happens over here, why there is increased amount of ketone bodies produced? Normally, the rate of synthesis of ketone bodies by the liver is such that they can be easily metabolized by the extrahepatic tissues. Hence, the blood level of ketone bodies is less than 1 milligram per deciliter and only traces are excreted out in urine which are not detectable by usual tests. But when the rate of synthesis exceeds the ability of extrahepatic tissues to utilize them, there will be accumulation of ketone bodies in blood leading to ketonemia and also the ketonuria, smell of acetone in the breath. All these together constitute the condition known as ketosis. And when the cause is the diabetes mellitus, we call it as diabetic ketoacidosis. So in uncontrolled diabetes mellitus, which is the most common cause for ketosis, here what happens is, even though the glucose is in plenty, the deficiency of insulin causes accelerated lipolysis and more fatty acids are released into circulation. So oxidation of these fatty acids increases the acetyl-CoA pool. Enhanced gluconeogenesis restricts the oxidation of acetyl-CoA by TCA cycle since availability of oxaloacetate is less. So now, which are the ketone bodies which are present? Acetone, acetoacetic acid and the beta hydroxybutyric acid. As I mentioned, the normal levels are less than 1 milligram per deciliter. Coming to the clinical presentation or the salient features in a case of diabetic ketoacidosis. It is a typical presentation of metabolic acidosis. Now here, because of the increased amount of keto acids, that is acetoacetate and the beta hydroxybutyrate, which are acids, they accumulate leading to metabolic acidosis. Then we have the reduced buffers. The plasma bicarbonate is used up for buffering of these acids, hence there is decrease in the bicarbonate levels. Next is a Kussmaul's respiration, where patient will have typical acidotic breathing due to compensatory hyperventilation, which was a typical breathing pattern in the case. Next we have smell of acetone, which is due to presence of acetone in the breath. Then dehydration is due to sodium loss. The ketone bodies which are excreted out in urine as their sodium salt leads to loss of the sodium, hence hyponatremia. So this further causes dehydration. Next is the electrolyte loss. One I mentioned is loss of sodium. And what happens to potassium? There is hyperkalemia, that is increase in potassium due to the insulin insufficiency. Then the patient can end up with coma. There will be osmotic diuresis too, which is induced by ketonuria, leading to further dehydration. Now, what is the biochemical basis of a case of diabetic ketoacidosis? Here, as I mentioned, there is hyperglycemia, as in this case, where it is the blood glucose level is 450 milligram per deciliter. But this glucose cannot be utilized because of insulin deficiency. So energy has to be constantly provided. So for that, there'll be lipolysis leading to fatty acid oxidation for further fuel needs. This overproduction of the free fatty acids, that is the end product being the acetyl-CoA, which is utilized in the TCA cycle for the energy purpose or for releasing ATP. Now, whatever acetyl-CoA what is produced is in excess, exceeding the capacity of the TCA cycle to utilize acetyl-CoA to release energy. That is because there is depletion of oxaloacetate for gluconeogenesis. Hence, acetyl-CoA takes the alternate pathway of synthesizing or producing ketone bodies. Hence, ends up with excessive production and accumulation of ketone bodies, leading to ketosis in a case of uncontrolled diabetes mellitus. Now, how do you manage a case of diabetes mellitus or diabetes mellitus with ketoacidosis? The presence of ketosis can be established by detection of ketone bodies in urine by one is the Rotheras test and the other one is the Gerhard's test, which is for acetoacetic acid. How do you manage a case of diabetic ketoacidosis? Main treatment is to give insulin and glucose. Insulin should be given to reduce the blood glucose level, but it should be given along with glucose. When glucose and insulin are given intravenously, potassium is trapped within the cells and fatal hypokalemia can occur. Hence, we should always monitor the electrolytes, especially the potassium levels, so that the patient doesn't go into hypokalemia and end up with the other complications. Next is a administration of the bicarbonate and maintenance of the electrolyte imbalance, that is sodium loss is there and hyperkalemia is there. So we have to see to that both the electrolytes are maintained within the normal level. Then we have the fluid balance because of dehydration, which occurs in a case of diabetic ketoacidosis, and further maintaining the pH of the body. So this is about the case of diabetic ketoacidosis.